We have Dr. Daniel Davis as part of the Catalina Island Medical Center, and he is on a conference call and still has a PowerPoint presentation ready for us. So we welcome Dr. Davis back.
Yes, thank you for being here. Okay, Dr. Davis, take it away.
All right. Can you hear me okay?
Yes.
Perfect. And you can see the slides?
Yes.
Okay. Well, thank you for having me again. It feels like years have passed since I was last there, and the world keeps changing under our feet. But this is a good time to do an update, which is actually scheduled a couple weeks ago before we've had some activity here on the island. So I've modified it a bit and included a section at the end to try and explain a little bit about how we're trying to handle the latest cases and the case control or case contact tracking. But I imagine that there will be a lot of questions, and in fact, one of the suggestions that I'll make up front is that perhaps the City Council help us organize a special session for business owners, particularly those that interface with the public, to explain some of the CDC regulations and how it might apply to their specific situations. But we can talk a little bit more about that at the end. So here you see, I try to find interesting pictures, and this is a picture of the spike proteins of the coronavirus. But one of the things that's been discovered since our last chat was that they are able to cloak themselves in these kind of sugary molecules called glycans, which are represented by those things that look like bushes from a model train set. And by doing so, they can kind of evade or avoid the immune system by surrounding themselves in camouflage. And so some of the drug targets are to try to get rid of those to expose the underlying protein and make it more attackable by the immune system. But I thought it was an interesting picture. And so what we're going to start with is what I'm calling a tale of two states. I'm going to do a little compare and contrast, and I'm going to start with a good example, a model state here, where you see from the beginning of March there was a rapid rise in cases, but a flattening of the curve, which was the buzz term at the time, and you see that nicely in this graph. And in this particular state, there were very early social distancing guidelines and stay-at-home rules put into place, coordination at a state level of testing as well as distribution of necessary equipment. Hospitals were initially filled with patients, but weathered that initial surge and then were since able to open back up and do more routine procedures. There was a very controlled, regulated return to, quote, normal life, although I don't know that anybody would consider anything normal these days, and continues to be an emphasis on social distancing, the use of masks, etc., until this past weekend that you see there on the right. So now we're going to contrast that with the not-so-model state, where we see that the cases continue to go up, and in fact, the steepness of the curve is even greater now this past weekend than it was during what we all considered the heart of the pandemic thus far, back in April. And in the press and the general consensus was that there was a lack of preparedness, particularly with regard to the availability of testing, things like PPE, ventilators, even some questions about the chain of command when it was a state issue versus a county issue, local public health, even mayors got into the fray. And then in May and June, we had demonstrations, political rallies, the onset of summer activities. Appears that people no longer paid that much attention to social distancing. The use of masks has been challenging. There's an influx of cases from outside the United States because this particular state is a border state, and that state continues to see record numbers of new cases, and the ICUs are running at 85% plus capacity. So here are the two states side by side, and on the left we have California. And on the right we have California. I present the exact same data and pulled statements that have basis in fact right out of the headlines to illustrate how frustrating this pandemic is to those of us who are trying to sort of hit a neutral ground and stay true to the science. Because presentations like what you see on the left, which is the exact same data as you see on the right, but presented logarithmically rather than linearly, the left-hand data has been used when we're trying to applaud governmental efforts, support gatherings including protests and rallies. Small business owners have used graphs like on the left to justify a return to normal business activities, and even hospitals, which were tremendously affected by this, and not in a good way, where most of their money-making activities had to be shut down during the peak, use these kind of graphs to justify reopening. Now on the right, we see those graphs that we're trying to establish that the government was reckless and that we returned to normal too soon, to criticize people who are gathering together for protests and rallies. People who are retired, like here on the island, didn't particularly want to see an influx of tourists in their peaceful hamlet, and would focus on graphs on the right. And to my dismay, even the scientists, whose grant funding and their moment in the sun somewhat depend on being alarmists and painting the worst-case scenario type pictures, have often tried to stir up fear in an effort to get people to comply with regulations. So this has been a very difficult situation to navigate, and never before have I seen something that's ultimately a medical and a health care entity become so politicized and so divisive. And so I'm going to try and bring some of this together and tell you what we think we know and what we definitely don't know. And so these are the graphs that I tend to watch the most. This shows California's cases, the new cases on the left, and the new deaths reported on the right. This is presented linearly, so it looks fairly steep, and you see that starting from April over here, and you should see, do you see a pointer on the screen now?
Yes.
All right, so from my pointer, you see pretty much a steady incline, accelerating at the end of May, beginning of June, and really accelerating from mid-June up into the present day. And yet we don't see a corresponding increase in deaths. In fact, the general trend has been a downward trend, or at the worst, a flattened trend. And so this has been the subject of tremendous debate as to whether there's suddenly a disconnect. And if you just do some back-of-the-envelope math and look at, say, early April here, where we had about 1,000 new cases presented each day, and around that same time we had, we'll say, around 50 or so new deaths a day. And then we fast forward to the end of June, where we were almost pushing up on 10,000, so a tenfold increase in cases per day, and yet really only a nominal increase in the number of deaths per day, and in fact from mid-April a decrease from about 75 down to about 60. So how do we explain this? Because this is critical to understanding what's happening, is to how we're going to interpret this. One initial explanation was that there was a lag between the new cases and deaths, and we've known that before, that new cases are often identified early in the course of the illness, and it may take 3 weeks or so. But I would suggest that, certainly from the middle of May to the present, we've seen a steady increase, and we just haven't seen that increase in the deaths. So for the first time in this pandemic, there's been a disconnect between new cases and deaths. Is it possible that we're doing a better job treating these patients? Well, there have been a few, I wouldn't say leaps forward, but at least steps forward. remdesivir, which had been identified early on as a potential candidate to treat, but unfortunately is only available as an IV formulation, so it was only reserved for patients in the hospital. The controlled trials did show a little bit of benefit, not much, maybe a 10% faster rate of improvement. And then in the past couple of weeks, we've heard about dexamethasone, which is a steroid, in a study that came out of England, where if you look at all comers, there was a little bit of a reduction in mortality. So over here, they're looking at survival or improvement, and here they're looking at mortality, so it flips, and we want lower. You see a little bit of improvement, which seemed to come from the sickest patients again, those in the ICU needing supplemental oxygen. In fact, it seemed to hurt people who weren't requiring oxygen. But I wouldn't say that you can explain this 5-fold or greater decrease in the ratio of new cases to deaths just by these two drugs alone. So there's something else going on. And part of it has to do with the patients being identified, this shift from just testing people who are sick enough to be admitted to the hospital, if you think back into March and early April, to now trying to test everybody, even if they have no symptoms, who may have come into contact with a COVID patient, and that will bring us eventually around to Avalon in a few minutes here, including people who have minimal or even no symptoms whatsoever, who really aren't at risk of dying but are being tested, and some of them are testing positive. So you can think of it like this: if this was the entire population of the United States, right now we think about 10% of us, represented by that pink circle, have been exposed and have either weathered the virus or are actively fighting it, even if we weren't even aware that we had symptoms. And at the beginning, that little dark blue dot represents the percentage that was actually being tested. And as we've had more availability of testing, we were able to test not just people being admitted, but people showing up to an urgent care or an emergency department, or maybe just people showing up to a clinic with some upper respiratory symptoms, or now patients who don't even have symptoms but may have come into contact with a patient who has COVID. As we get closer to identifying all the cases, even if there hasn't been a net increase in the cases, it would look like there was, just because we're identifying more and more patients. And that could explain why the caseload would go up and the mortality really hadn't dropped much at all. Now, kind of on that same vein, there's even been a change in the type of people that we're testing. When you open up roadside testing, where somebody can drive up and get tested, it favors a more mobile population, and we're seeing younger people who are diagnosed, and they tend to be healthier and less likely to go on and die from the disease. And in fact, in many hospitals, including in Catalina Island Medical Center, we're testing everybody who has to come in and out of the hospital on a regular basis, whether it's somebody who's there for work or even patients who are making use of some of the outpatient facilities like physical therapy, where with routine screening you may be more apt to identify a patient who really didn't think they were sick but turned out they have a positive test for coronavirus. Now, one of the things that's been questioned in the last couple of weeks is the idea that maybe we're over-reporting. That, in fact, in some states they admit that whether you had an antibody test or an antigen test, that both were being reported at cases, and the possibility that even the same patients are being counted more than once. And that would be a real issue, especially with some of the return-to-work strategies being based on multiple negative tests. And we've already seen something that we'll talk about in a second, where patients may have positive tests going on for months, even when they're really not infectious anymore. But nobody is sure whether those patients are being counted twice or 3 times or even more, and that we're not really seeing an increase in cases, but instead we're just seeing over-reporting of cases. Now, one of the theories that I like is that the virus may be different, that it's mutating, and that it may be a virus that's less apt to lead to mortality, less apt to kill you. Our commander-in-chief suggested that might be the case, and while he's certainly not anybody's idea of a medical expert, his reporting of this is not without foundation, because there are geneticists who have identified already that the virus that we see today is different than the one that was here in March, and that in the West Coast in particular, mostly we've seen this mutated form, and that one of the genes that's mutated seems to be one that helps it escape the immune system, so maybe it results in a milder form of the disease. Now, that doesn't sound like it would be something a virus would want, but we tend to assume that this virus is evil and trying to destroy the human race, when in actuality, the virus would love to be asymptomatic. Its way that it passes on from person to person is by making sure that people come into contact with each other as much as possible. And so a form that had milder illness, where we don't pull those patients into hospitals and seal off the walls, but we let them go to bars and nightclubs and touch each other and pass it around, that would be ideal for the virus. And in fact, we have a precedent for this. SARS-1, back a decade or more ago, followed exactly the same pathway and eventually mutated itself into a form that really didn't cause much in the way of human disease at all. So I would love to assume that that's what's going to happen here with SARS-CoV-2, our current coronavirus. But so far all we have is that first mutation that suggests that we're going to see several mutations. And here we see the head of infectious disease in Italy, who described it slightly differently, saying that he's downgrading it from a tiger to a wild cat. Now, what's interesting is how much political backlash he received, even in Italy, from government officials in Italy and even the World Health Organization telling him to button his lip, because that's making people less apt to follow guidelines and more apt to go out and spread it around. And so it's interesting that even other countries have had the same sort of political divisions that we've had here, when somebody's trying to make a clinical observation and tell what he sees as the truth and is certainly an authority, and is quickly jumped on by public health. Now, this is a graph that I've presented before that shows you that there's a lag time between when you first acquire the infection and develop symptoms, and then get sick enough to go to the hospital, and then get sick enough to die. 3 to 4 weeks may have passed, and so what I've showed you so far looks on either end. When you first get the disease, even before you get symptoms and are now a case, versus waiting until the other end, until we see actual deaths. So is there anything else that we can look at that can give us a clue as to what's going on? What should we be watching as our main indicator that the disease is on the rise, or that things seem to be pretty much leveled out? Well, this is one I have showed before, and this is one I have access to as the Riverside County Medical Director for the fire department, where we track every week the percentage of emergency department visits and EMS calls for ILIs, influenza-like illnesses, because for the most part, the patients who get sick enough to go to the hospital, either by ambulance or on their own, have something that looks kind of like the flu. And so you can see over here in December, January, we saw the actual flu, influenza. That sort of tapered off. Then we saw our initial spike in coronavirus cases, and that kind of tapered off. And we are seeing an uptick. It hasn't gotten anywhere near what we saw back here in March, where we're only at about 2 or 3% of emergency department visits and only about 1 or 2% of EMS visits or EMS runs. So we definitely aren't seeing something that parallels the idea that we're seeing record number of cases and that we should be sort of in a panic, that it's nothing like it was back in March or April, although it is on the rise, so it's definitely something we're keeping an eye on, but not to the same extent that we saw before with that steep rise to 10% of calls and 10% of ED visits being related. Well, what if we focus on the hospital? That's what we were promised, is that decisions about opening and closing society would be based on the availability of ICU beds. And you'll hear things on the news like 85% or 90% of the ICU beds are full and we're near capacity. And I'll tell you that's a little bit artificial, because hospitals have to run close to full capacity to survive financially. If you have a hospital that only has 30% of its beds full with 70% capacity for new COVID patients, that hospital is going to go out of business. And in fact, they try and adjust the number of elective surgeries, for example, to make sure that they always have some ICU beds available, but that they keep the hospital as full as possible. And that's what we've seen in the last month or two, is hospitals starting to take their foot off the brake a little bit and allow a return to semi-urgent surgeries and semi-urgent cardiovascular procedures where patients would end up in the ICU, and keeping some ICU beds available for COVID patients. And so this one even is difficult to track because it's somewhat affected by how much the hospitals allow a return to normal activities versus not. But you can see since March, we've had about the same number or same percentage of hospital beds available, maybe a little bit less starting in the beginning of June, but nothing dramatic in the last month or so. Now, the statisticians are tracking things that are a little bit more nerd-worthy, I guess, looking at how quickly the virus is moving through the community. And one of the things that you've heard is this mutation that I mentioned previously may have increased transmission, whether that's something because of the mutation or just because people who have the virus now may not be as sick and are transmitting it to more people, not realizing that they've contracted coronavirus. But either way, we saw at the beginning of June a little bump up in the transmission rate that's circled there in white, and then it's sort of returning back down to the magic number where the transmission is 1, meaning that each person transmits to one other person, but no more. And ideally, you have a number less than 1, meaning that it's starting to decrease in the community. So we are looking at how fast it's transmitted, and it looked like our little peak came sometime around when things were opening up and when we saw a lot of gatherings and activity and stuff. And now it's starting to drift back down. Well, then we try to use those to predict how many ICU beds is that going to require. And so this, again, is data from LA County, where you see the best estimates are the white line, the red sort of shaded area, and the pink shaded area, which represents worst-case scenarios. And then you see the actual data with the white dots, which seems to be just chugging along. Now, this particular graph ended towards the middle to end of June, but you can see that even the estimates aren't particularly accurate, and that, if anything, epidemiology and public health has a tendency to overestimate. They want to prepare for the worst-case scenario because they're less likely to be criticized. And to tell you the truth, as we used to say, it sells more newspapers. These days it sells more clicks on the internet, or at a minimum ads on CNN, to tell everyone how horrible things are going to be, rather than to be hopeful or to just stick to the data and say, so far there hasn't been a whole lot of change since the middle of May as far as the demand for ICU beds in LA County. All right, so that brings us to Catalina Island, and I found a very apropos photograph or picture for you here, because we really have seen now in the last week or so, for the first time, what community spread looks and feels like. And as you might expect, there's been a little bit of panic, might be a little bit over dramatic, but certainly concern, and people wanting to try and keep themselves and their families safe, which is perfectly appropriate. So here's where we're going to try to dig in a little bit and show you the way that we're thinking about it, invite people to comment and ask questions. But like I said at the beginning, I would suggest that we perhaps have a separate sit-down with some of the folks that interface directly with tourists so they can better understand what the CDC guidelines say and can try and weather this not just from a medical perspective but from a financial one, because if we're stuck with this virus for another 6 to 12 months, then we've got to figure out a way to keep our businesses open but keep everyone safe at the same time. I think we've done a good job at CIMC at keeping everybody posted. Very nice, clear website. So 9 people that have had a nasal swab positive and 7 more that have tested positive for antibodies, meaning that at some point their immune system has seen it at some point in the past. And interestingly, this has not been coming in from tourism, but has been from people who live on the island, often traveling off the island and bringing it back in, and now with a little bit of spread on the island itself. So I think perhaps we probably over-focused on the idea of the tourists being the ones to bring it in, and under-focused on the potential for each one of us who travels back and forth to bring it to the island. I think, not to pat ourselves on the back, but in many ways I look at the leadership of CIMC, and I'm just an employee, so I look at the leaders and really admire what they've done and stepped up in order to provide a service to the island. And I think thus far the efforts to identify patients, monitor them medically, to make the right decisions about when they need to be sent over town for admission. Those who have been admitted have legitimately needed to be in the hospital for several days, but none have gotten so sick that they've required prolonged mechanical ventilation, and so far, knock on wood, even patients with comorbidities have done well. Our long-term care patients have been sequestered and thus far have been without cases. And to some degree, the hospital activities have started to return to normal, including outpatient visits and services like physical therapy, mental health services, etc. We are waiting for point-of-care testing for the antigen. That is, do you actively have the shed of virus from your nasal pharynx? Right now, we have a point-of-care antibody test, and I'll talk a little bit more about that in a second. But what I'd like to do is try with pictures to explain the way that I think about this, with the knowledge that we're still learning about this virus and all the rules that we used to use have changed, making this difficult. And that's part of the reason why we haven't opened up roadside testing where anybody can get tested at any time. But instead have said, we'll test anybody. We just want the opportunity to talk to you a little bit about the situation, make sure that all the appropriate follow-up is being done, and make sure the right tests are being ordered and that you understand what they mean. So, without further ado, this represents an individual being exposed to coronavirus on day 0 and going through some kind of incubation period before they develop symptoms. Now, on the average, that's about 4 days, but for some people, it goes all the way out to 2 weeks or 14 days. So that's why if there is an exposure, you should be quarantined for 14 days, because we will not necessarily know whether you have contracted the virus for that entire period of time. And we'll talk about testing in a second, but it is possible that all of your tests during that incubation period would be negative all the way out until that very last day when you develop symptoms and potentially turn the test positive. Now let's go back to the typical. So let's say that typical course, 4 days, and now you start to develop symptoms. Still mostly respiratory, although we're learning a lot of weird things, gastrointestinal symptoms, lack of smell, lack of taste, even some neurologic things. But for the most part, there's going to be cough, there's going to be some shortness of breath, there's going to be flu-like symptoms of fever, achiness, general malaise, and now they've even added a stuffy nose, which this coronavirus up until now seemed to bypass the nose and go right into the lungs, but now maybe because of the mutation, it tends to linger in the nose and give you a stuffy nose as well. Now, The best data that we have suggests that once you develop symptoms, that you will be infectious for 10 days. So your period of contagiousness goes from somewhere after the exposure out to 14 days. Now, aren't there some people who have a longer infection? Absolutely. So how do we account for those? Well, what we've done is we've said that to end on that 14th day or 10 days of symptoms, the last 3 have to be without fever and with at least a decrease in your respiratory symptoms, a decrease in coughing, a decrease in shortness of breath. So that way we sort of know the disease is coming to a close. And you're going to see that magical 10 days in a lot of different situations. From the onset of symptoms, it's 10 days, or from when you got your test. Then we count 10 days, and we assume that as long as the last 3 was without fever, that at that point you're no longer infectious. Now, one of the things about this virus that's thrown us a curveball is the fact that you can be contagious and not have symptoms, the asymptomatic carrier. For some people, that can be the whole 14 days, and so that creates huge problems. And if everybody was an asymptomatic carrier, then we wouldn't even know about the virus to begin with. But because one person can be asymptomatic and pass it on to another person who's perhaps older with other medical problems, and it can lead to a life-threatening disease, is part of what's made this so crippling. But because of that asymptomatic period, then it's possible that you don't even have symptoms, but you're getting a test. Maybe your boss told you to get a test. But you get a test and it's positive, and so then the 10 days starts from that positive test. So that's why that arrow there on the top changes to yellow, meaning you may get the onset of symptoms, and that's the first of the 10 days, or it may be the day that you had the positive test. Now, we may not get the results of the test for a week now, but we count from the day that the test was obtained from your nose. That's the first day when we're counting those 10 days. We'll come back to that. At some point, you go into a recovery phase. You can have a lot of coughing. You can have some shortness of breath that remains, even some neurologic symptoms. But if you're past that initial period and you're without fever for 3 days, then we call it the recovery period. And at that point, we assume that you're no longer contagious. In an ideal world, the antigen test, the one that's taken from your nose, would track perfectly with your contagiousness. It kind of makes sense if you got virus coming out of your nose that we can find with a swab. Wouldn't you be contagious? Well, another weird thing that we don't understand about this one is that some people continue to shed the virus from their nose for months, and we've already seen it here on the island. Now, for a long time, we thought they were still infectious, so we just kept people inside as long as their nasal swab test was positive. And then the South Koreans, who went through this a little earlier than we have here, checked and found that the stuff coming out of these folks' noses isn't viable virus anymore. It's dead. It's little bits and pieces. Why your immune system continues to shed it out of your nose, nobody knows at this point. But for that reason, and the restaurant and hotel owners ought to be listening closely, we can't and we shouldn't rely just on that nasal swab to decide when somebody's no longer contagious. We were hoping that would be the case, and the CDC guidelines still have an alternate route that says if you have 2 negative tests in a row after you tested positive, if at some point you have 2 negative tests in a row on back-to-back days, then you're no longer infectious. And that's true. The problem is for those poor folks who keep shedding dead virus out of their nose, they may not go back to work for 2 or 3 or 4 months. We don't know yet, because there are people who are still shedding it months later. And that's too bad, because they're not truly contagious. But for them, you ought to use the alternate, which is that 10 days, as long as the last 3 didn't have fever. And that may sound rash, but the fact that we're all still wearing masks makes it even safer to do it that way. I have to admit that if I knew somebody was still actively shedding dead virus, I'm not sure I would put my finger in their nose and put my finger in my nose right afterwards, even knowing what I know. But the fact that everybody's wearing masks, I have very little concern, and I'll show you some other data in a second that support that. Now, what about the blood test? We have that on the island, and we have one of the best ones on Earth because Lyra, the lab technician or the lab manager, happened to have a good relationship with a South Korean company and had been working with them before. And so we have one of the best ones, and in fact, it seems to pick up cases almost as quickly as the nasal swab. And in the fact that we can get the results back in 20 minutes, we're getting positive results back, days, even a week before we're getting the nasal swab test back. So one thing you may see us pivot towards is the idea that if you've got symptoms, we may go ahead and test the antibody test at the same time as the nasal swab, if only because if you have symptoms, we can assume that the symptoms are related to the fact that your blood test is also positive, and we get the results so much faster. It really wasn't supposed to be that way, and if we get a point-of-care nasal swab, which is the antigen test, then presumably we would catch people way back here with a positive nasal swab even before their antibody test turned positive. But the way that it's explained on TV, which is generally accurate, is that the antibody test tells you that you have had the coronavirus at some point in your past. We just didn't anticipate that here in July we'd still be waiting a week or longer to get the antigen test back, and that for some patients, when we're swabbing them here, we get a positive antibody test before we can get the antigen test. So be prepared for a little bit of flexibility there, and hopefully once we get the point-of-care antigen test, we won't even have to think about that. But at any rate, we are starting to test people simultaneously with the blood test and the nasal swab, and the only person that potentially would be impacted negatively by that would be if you had coronavirus back in March and nobody ever identified it because we didn't have tests back then, and then you just get nasal allergies, and we swab you and we check your antibody test, and the antibody test comes back positive, and we say, you've got coronavirus, and then a week later we get your antigen test back and it's negative, and they say, oh, it probably is just nasal allergies, and that thing you had back in March was probably why your antibody test is positive. Now, the antibody test is an interesting one because many have said maybe we should use that to decide who should work with the tourists, because if you've got antibodies, technically you shouldn't be able to get it again. And in fact, as we start thinking about a vaccine, having antibodies may be the thing that tells us that somebody is immune or that they need a booster for the vaccine. And so there's a lot of interest, and we just don't have a lot of time yet. We've only been 2 or 3 months out, but already, as you might have seen Dr. Fauci say on the news in the last week, we see some patients whose antibodies seem to drift down and go away fairly quickly. And that may mean that the immunity to this virus doesn't last that long. I'm hoping at least it lasts for a year at a time, so we'd only have to get an annual shot like the flu shot. But so far, the data are kind of mixed there. All right. So let's look at this a slightly different way and make this about an individual. So here we have an individual who works with somebody at a restaurant who tested positive. And so the last shift they worked was last Saturday, and that's going to be your exposure day, day 0. So here we are, it's Tuesday, and so the first question is, are you having any symptoms? If so, we start the clock ticking, and we've got 10 days, as long as there's no fever in those last 3 days, before you can go back to doing what you would have done before and come out of quarantine. Or maybe you're going to get your test now that it's Tuesday, and we're going to not know the test results for a while, probably not until day 11, but at least we got the test acquired on that 4th day, and if that test turns out to be positive, then again, it's 10 days from today when we got the test. Now, what if this is you instead? And on that 14th day, which would be 10 days after you got the swab, or 10 days after you, or 14 days after you got exposed, that you finally develop symptoms 2 weeks after you worked with your coworker, and then you start the illness. That means that you're contagious all the way out to 24 days, assuming that those last 3 were without fever. So the length of that incubation period is important. And it's possible that if you got tested back here on day 4, that test would have been negative because you didn't have enough virus yet to even turn the test positive, much less have symptoms. So even a negative test early in the quarantine period doesn't mean it's safe to go back to work. You still need to be under quarantine if it was a true exposure. So again, the folks who own restaurants and hotels ought to be listening, and I think we probably should go through this in a separate session. But sending someone in 2, 3, 4 days after they worked with somebody who tested positive, if they get a negative test, they're not out of the woods. They can't go back to work because we have to wait through that entire 14 days. Or if they start having symptoms back here, like I said, then you start the clock for 10 days. And God forbid they start having symptoms on that 14th day, because now you got to start the clock again for 10 days and hope that the fever breaks for those last 3. This is why we want people to work with us, because it gets so complicated. And I would say that 90% of the cases, oh, and here's all your negative tests till you finally get a positive test here. I'd say most of the cases I've seen so far have not been the people who are actively exposed to somebody. It's been family members who stay in the same household, and then when that person finally gets their test results back here, decide now we're going to leave the house and quarantine. So now their clock starts the last time they were with the person that we know is positive. And so it could be a 28-day or a 25-day incubation for a family member just because they wanted to stay in the same house with somebody until they got their test results back. Now, if they gamble and the test results are negative, then they can stop at that point. But again, this is so complicated, and it's so complicated because of that initial asymptomatic period that you need to work with us to figure out how to do this. And I give my patients a lot of different options. Say, we can separate you from your husband, and we can start the clock now, or we can gamble and predict that his test is going to be negative, and that way then you don't even have to worry about it because his negative test means that you weren't exposed. So that brings up probably the most important concept of the night, and that is, what is an exposure? Because right now everyone is so nervous that they are assuming that just being in the same room as somebody is an exposure. And so the concept is that it takes a certain number of virus particles to get you infected. Now, if somebody sneezes with a lot of snot right into your face, that's a high concentration, and it only took that one sneeze to do it. But if you're just talking to somebody, and especially if you're wearing a mask or if you're across the room, the concentration may be so low that you are never with the person long enough in order to get enough virus to get infected. So it's definitely more than just being in the same room as somebody, passing by them briefly, and all of the modeling was done without people wearing masks. We'll come back to what the masks do because a lot of people have challenged them, and they've unfortunately been thrown into the political soup as well, with the mask wearing being somehow a form of suppression or control by the government, when it's just a way that we try to keep boogers from passing to one person from one person to another, because the virus isn't traveling in tiny little particles like little flies. They are riding pieces of respiratory secretion, snot and moisture coming out of your nose and your throat. And so anything that can stop those big pieces of fluid and mucus is going to reduce the viral load and reduce the likelihood of getting infected. And that doesn't matter if it's a bandana, a surgical mask, but as you move towards higher and higher quality masks, it blocks more and more of the particles or the secretions that would potentially have virus on them. Touching somebody that a COVID patient handled, that turns out to not be much of a thing. So watching the CNN doctor spray off his cornflakes with his family with bleach is something I've now saved that I'm going to show my grandchildren as how ridiculous this got, but it's not something we need to worry about. And wearing gloves isn't really going to do anything either. In fact, your skin is a great barrier for virus getting in your body, as long as you wash it every now and then, especially before you touch your eyes or your nose. So the best thing would not be to wear gloves. It would be to have hand sanitizer at your station, and every time you come into contact with somebody or periodically through the day that you hand sanitize and keep the viral load on your hands at a minimum, and try not to touch your face and your nose, etc. The CDC defines an exposure as being within 6 feet of somebody for at least 15 minutes total time. And so as I trace through at these restaurants and hotels, there have been very few people that work so closely with another person that they fall into this category. And that's important because that gives you the latitude of, instead of sending 30 people home and closing down, it says there are maybe 3 people that fell into this category that we need to isolate now for 14 days or 10 days until after they have a positive test, or 10 days until they start developing symptoms. But there's only a small number of people that need to be isolated because they actually had an exposure. And here's a few numbers for your next cocktail party, hopefully not anytime soon, because cocktail parties and bars seem to be a good way, since we don't wear masks, to spread it around. But some interesting tidbits here. People in the same household, husbands and wives, have less than 25% chance of transmitting it to each other, which is interesting because it seems like people sitting in a bar are having more intimate contact with each other and a higher rate of transmission than a husband and a wife. And teenagers in particular seem to have very low risk because they don't seem to ever say anything to their parents or spend any amount of time with them. But it's striking to me how low the chance of transmission is. For me, I'm responsible for over 3,000 providers, half of those being helicopter flight nurses and paramedics, and the other half being paramedics and EMTs in the Riverside Fire Department, who collectively have literally taken care of thousands of COVID patients, including doing intubations, giving them nebulized treatments, all the things that increase transmission and are supposed to force you to put on your maximum amount of personal protective equipment. And we have 0 transmissions from patients to our staff. Now, we've had about a dozen people who have contracted COVID on their days off. So we're much more careful when we're taking care of patients than we are in our personal lives, unfortunately. But there has been 0 transmission from patients. So if you use the proper precautions, you can keep yourself from getting this. And yet you see these idea of super spreaders at bars and nightclubs and other mass gatherings. And so it really is a matter of maintaining the proper sanitation and personal distance. So what I would suggest is that if you have to deal with, quote, outsiders, whether that's tourists or whether we're talking about going to visit people in areas that have a higher incidence of COVID, that you should wear a mask and sanitize your hands. And just like our paramedics and flight nurses and EMTs, you will not get it. That's particularly true if at your house there are people who are more vulnerable, older people, people with comorbidities, and that's a common scenario on Catalina Island where there are multi-generations living in the same household. And so those of you who are on the front lines should behave the same way that we do as healthcare workers, wearing the mask, sanitizing the hands, coming back and trying to wash yourself off, change your clothes before you interface with anybody who's vulnerable in the household. With any symptoms or with a true exposure, you should get tested, and we'll test anybody. We'll test you even if you didn't have an exposure. We'll just explain to you how this works and make sure you understand that a negative test today doesn't mean that you can't catch coronavirus tomorrow. The antigen, again, that's the nasal swab, tells you that you have active virus coming out, with the caveat that it may be dead virus after that 14 days or the 10 days of symptoms. And the antibody testing is maybe for the long-term immunity, but like I said, our test is performing really well here, and because we get the results back so quickly, you may get both if you have symptoms. And then for businesses where there is a identified individual, then truly trying to figure out who was exposed. And again, we understand that you want to be cautious and test everyone, but that's where I think we should have a separate session to explain that you're going to cripple yourselves financially if it continues to percolate through the community and you shut down every single time, that there are better ways to do it. And please be kind to each other. The few individuals who have been unfortunate to contract this have been treated like lepers, and that's unfortunate because this could be contracted by any of us because of the asymptomatic spread, and that for the most part they have been trying to comply with the recommendations and do everything we ask, but the last thing they need is to be excluded and ostracized, even in some cases in an aggressive way. All right, when's this all going to end? Well, what's the status on the vaccine? So far, there are dozens of trials going on, and we've got some big players in this game. Some of the big pharmaceutical companies like Pfizer are involved, and it looks like thus far all the vaccines are safe. They have been able to generate antibodies. We don't know how long those antibodies will last. Those antibodies that they generate do seem to be able to bind to the virus and suppress disease in test tubes. So everything looks good, and now they just have to prove that it works in a large population of people who are getting coronavirus at a rate of 2, 3, 4% at the most. So you need lots of people, and those trials have already started. And so our hope is that at least one of them will be a successful trial and that we will see vaccine available this fall. I am almost certain there will be a vaccine. Now, how it will be distributed is anyone's guess. One thing that we've seen for the first time ever is companies bet tens of millions of dollars on the vaccines being successful and starting to ramp up production so that there is vaccine available even before we know if it works. And that's a bet that they're going to make in order to try to have vaccine available prior to this flu season. Because if this coronavirus behaves like other coronaviruses, it likes the winter months better than the summer months, and we may see a spike this fall. If there's a limit as to how much is available, it will likely be distributed to healthcare workers and people who are vulnerable, including the elderly and people with other illnesses first, and then made available to everyone else. But again, the companies are going all in on this stuff. There may be more than one vaccine available, and it may be that all of them are effective, and we won't know for several years which is most effective, but that having something on board, even if it doesn't stop you from getting the virus, will make it a much less severe form of illness. And again, as I mentioned, the antibodies seem to fade faster than for other viruses. Measles, the antibodies last your whole life. Coronavirus, I would be surprised if we didn't have to have a booster every year, at least until it disappears from the earth. Now, one of the drugs that I mentioned to you a couple months ago is entering larger trials, and the best sign that it looks promising is that Merck, rather than investing in a vaccine, is investing in this drug. And what makes it unique is that it seems to, A, be immune to the mutations thus far, knock on wood, and B, most importantly, it's available as a pill, not as an IV thing. So it would be like Tamiflu, but probably even better because it seems to work against all flavors of coronavirus. So it'll be very exciting, and we wouldn't need as many patients to show that the virus levels drop and that the clinical symptoms decrease. And so I would bet that we will see this drug available on some basis as early as September, and if Merck's involved, they'll probably mass produce it so that everyone who gets the virus will have access at some point within the next flu season. And maybe the virus will continue to mutate and weaken and follow the path of SARS-1 and it will disappear. And so with that, on that hopeful note, I will stop, and you'll probably have to read me the questions or repeat things if people are calling in. But hopefully that wasn't too dense and gave you some appreciation for what we're trying to do and why this is so complicated.
Yeah, once again, you nailed it, Dr. Davis. Thank you. We'll go to questions, but we just can't thank you enough for all of this information. It's fantastic from the local level all the way to what's happening, in California. So thank you. And we have questions. Michael?
Yes, I have one question from Kathleen Hill Carlisle. She writes, contact tracing is a critical tool in a community's effort to stop the spread of COVID-19. Contact tracing stops the chain of transmission through rapid isolation of positive cases. Many of us are concerned that this is not happening quickly enough, and that the tests are taking way too long to get back. Contact tracing identifies and quarantines those in close contact with positive cases. There have been people out and about instead of quarantining after exposure or while waiting for test results. Can you do anything to implore these people to stay home? Additionally, employers play a vital role in contact tracing. With the responsibility to provide a safe workplace, employers have a vested interest in quickly notifying employees of a potential exposure to COVID-19 to keep employees healthy, maintain customer and employee confidence, and reduce the need to close facilities. In other parts of the country, alliances of the area's largest employers have created, quote, healthy workspace guidelines, unquote. Can the city help our employers do the same so that everyone is on the same page when cases hit, especially since so many people work in multiple businesses? Below is a link to a document from Seattle Alliance of Businesses. The key steps employers can take to prepare their workplace to support contact tracing efforts are: 1, be prepared to make a plan. 2, establish a COVID-19 point of contact. 3, strengthen channels to quickly identify COVID-19 cases. 4, take swift action once a case has been identified. 2, A, support the sick employee. B, protect the health and safety of others in the workplace. And C, partner with public health to reduce workplace and community transmission. Thank you, Kathleen.
Yeah, I'm not sure there was a true question in there, but it was a beautifully crafted statement that could probably be published somewhere and posted somewhere, because clearly she did her homework and even had links. Now, my response to that, since there wasn't an exact question in there, is to say that from the standpoint of what we're trying to do, there are two things. Two things that are going to make what she's saying a reality. One is the acquisition of point-of-care antigen testing, so that if somebody felt that they were exposed, they could immediately come to the hospital and get tested. Now, then the rate-limiting step is not that it takes 7 days to get the results back. It's that it takes potentially up to 14 days for somebody who's exposed to grow enough virus in their nasal passages in order to turn the test positive. And I've been likening it to a pregnancy test. If you send someone in the day after they had intercourse for a pregnancy test, I can tell you it's going to be negative, but it doesn't mean that that individual, I guess you could say that female, is not pregnant, but that it takes a while to get to the point where you turn the test positive. And so if during that period of time the behavior of the individual is such that they assume that they're positive until they get to that 14-day mark and they behave accordingly, then we're all okay. My fear is that people interpret that negative test as a sign that they don't have the virus, and all it means is that they don't have enough of the virus to turn the test positive yet. And I think if we get the point-of-care test, we can come up with some kind of protocol that would allow us to test periodically, so that as soon as we can identify an individual as being positive, we can start to do that case contact testing. Now, the second thing that we're doing is trying to work with the public health department and convince them that even though we are a very small percentage of Los Angeles County, and that every public health department in the country is running themselves ragged trying to do anything that resembles case contact testing, that we deserve special consideration out here because we're a unique population. That definitely worked when it came to getting medications and equipment. It worked when it came to getting N95 masks. So far, it's getting mostly lip service, but I have to tell you that the public health departments were not prepared for a nationwide pandemic. All of the training that we did was for things like a bioterrorist event where something happened in a single area at a single moment in time, and then we had to figure it out from there. But the idea that the entire nation is going to be affected simultaneously, and to make it worse, public health officials in certain areas have had their lives threatened, have been vandalized, are being blamed for people's businesses going under. And so compared to what I see over here on the mainland, Catalina has been a model of get-alongedness. I'm sure there's a word that means that, but I just can't think of it at the moment. But I think everyone appreciates that there are different perspectives here, and that if you're an 85-year-old retiree with diabetes and heart disease, your perspective on whether the tourists should come back is different than if you're a business person who's trying to feed a family of 5 on a salary that no longer exists. And everyone has been fairly mutually respectful, and for the most part are trying to get the best path forward for everyone. But if we can't get that public health official stationed out on the island to do true case contact testing, where they're allowed to go in and get in people's business and let them know they've been exposed, where the hospital cannot because of all the rules we have to follow, the best we can do is sort of like what's been happening, where the businesses and individuals are trying their best to notify and let people know you might have been exposed, please go get tested. But again, the problem with this is that period of asymptomatic spread, and that has thrown all the rules of epidemiology out the window, because again, just because you tested negative 3 days after you last worked with someone doesn't mean that you don't have it, and that the best path forward is going to be to truly separate exposures from people who just happen to be in the area. Because we don't need to test everybody who worked in the same building as somebody. We need to test those who came into close contact. And if you're wearing your mask, that mitigates the risk substantially. So there, I answered a question that wasn't asked.
Sure, thank you.
Yeah, and I received one more question. This one is from Paula Patterson. She writes, what is your opinion of a point of view I've read that says that if for an extended amount of time people comply with the 3 issues we are told diminishes the likelihood of transmission, that includes wearing a mask, washing your hands, and social distancing, the virus abates because it cannot find a host and eventually dies off, or at least diminishes? What is your viewpoint? Thank you so much for this relevant and informed information, Paula Patterson.
Yeah, I mean, that definitely works, but I think one of the interesting social phenomena that has emerged out of this is how much Americans value their freedom. And in this case, freedom doesn't mean the freedom to own a gun or the freedom to say or do whatever you want, but even the freedom to not wear a mask. That people get to the point of blows and certainly vehement insults when they're challenging the idea that someone else can tell them that they have to wear a mask. And it's a very sharp division between those who think that that's the right of a government and a society to take care of each other and impose that, versus those who say that you can make the suggestions, you can offer the scientific perspective, but you can't tell us that we have to do it. And in fact, if you do, I'm more likely to flaunt it. And that leads to, then a new phenomenon in the last 10 years of people trying to humiliate each other on social media, and the term Karen to describe someone who throws a fit if they're being criticized for not wearing the mask, and it's so far outside of what we learned about public health in school that all the rules are being rewritten. And when you look at other countries, in most cases, there is a natural deference to authority to where people will follow what they perceive to be law or rules exactly as spelled out without challenging them, and that has led to a very rapid disappearance, for the most part, of the virus in society. Now, there's a lot of suspicion maybe the most authoritarian governments that have the most control over the minds and the actions of their citizens are also hiding cases. And so I don't know if anybody completely knows the truth, but if you're truly interested in this, the most interesting case report has been Norway versus Sweden, which are two very similar societies as far as their genetic similarity and their general outlook on life. In fact, I have both sets of genes running in my own blood. And in one case, the government decided to impose a strict lockdown. They saw very low death rates, very low transmission, disappeared quickly, but they suffered economically, and now only 1 or 2% of people have antibodies, as opposed to in Sweden, where they sort of let it run its course. They offered some guidelines, and people often chose to wear masks, but definitely not 100%, and people were still eating in restaurants. They had higher death rates, although not as high as Italy or UK or the United States, but higher than in Norway, and about 25% of their citizens seem to have antibodies. And there's been a lot of debate because economically they didn't suffer as much, but they did have perhaps a higher death rate than they needed to have. And it's led to a lot of discussion about what the right role of government is and how you measure protection of the economy against protection of vulnerable individuals, potentially even including people at the end of their lives in nursing homes, and how far you are obligated to extend. And so I agree with the sentiment of the question, but I also recognize that in America it is impossible to enforce the kind of social isolation and hygiene that it would take to see the virus peter out the way it has in other countries. And so as a realist, I recognize that we're not wired that way at this point in our history to be able to comply enough to see the virus disappear this way. And I think for us, it's going to take either a major mutation or the vaccine and or therapy to see it disappear. I don't think we're going to be able to do it with public health measures.
Council, do you have any questions?
Can I have Captain Hawking see if anybody on the outside has?
Sure. He says no. I have two questions, Dr. Davis, and so if you were, well, you are a physician, so in terms of schools opening, do you have any medical opinion on how you think schools should be opening, or should they be opening?
I personally agree with the idea that the children, for whatever reason, I think we haven't completely identified, are at very, very low risk of suffering any health consequences. And I think the only point of discussion becomes, are the children at risk for carrying it to their grandma and grandpa, who are then at risk of dying from the disease? And there are some interesting data that came out of New York City saying that not only are children not as likely to suffer a true illness, but they don't even get it for some reason, that even children of workers on the front lines in New York City and children of people who ended up contracting COVID didn't get it, and they certainly didn't spread it around to each other at their daycares because they had to maintain daycares there. And so there's a lot of debate within the public health community about whether we can take that lesson or that observation and apply it now to our schools, out here where we haven't had nearly the impact of coronavirus as they had in New York, but are still seeing active cases. Personally, I think I would like to see kids return to school, but that is my own opinion. I think that we have to get into the habit of kind of sanitizing before we come through the door, and that's harder with younger children. But I think if you've got vulnerable people in your household, you have to treat it to some degree the way we, like I mentioned before, the way that we treat our own families coming back from a shift in the emergency room, or the way that we've treated the nursing home to some degree. But I think that it's safe to go back to school now. At the same time, I see that there's going to be an irreversible shift towards alternate learning that includes things like homeschooling or learning online. And I think that will be true for medical education, that will be true for meetings, that will be true in all aspects of our lives, including school. So just like our own kids' school, they're offering different models that you can come back and be 100% in school, you can be 100% homeschool, or you can have some sort of blend. But from a health perspective, I'm okay with a return to school because I don't have any fear for the kids. But if I were in a household where the kids are in constant contact with vulnerable individuals, I would establish a routine to make sure that they are, quote, sanitized before they have contact with the vulnerable patients.
Okay, thank you. And what about, and I'm probably screwing this up, but minority populations being more deaths among minority populations than Caucasians? Where do I hear that? And why do I hear that?
There's no question that the data support that non-white populations have been harder hit by the coronavirus. And I think the debate divides between this being something genetic, because there are clearly genetic things about this. I mean, type A blood, for example, has a much, much higher likelihood of complications than the other blood types, and type O seems to be the best one to have. So there are likely going to be things identified, which are true of a lot of different diseases, that fall along ethnic and racial lines that are attributable to the genetics. That being said, and certainly with the political climate or the social political climate of the last couple of months, I think there are some legitimate accusations that this also falls along access to health care and access to quality health care, and biases that healthcare workers may hold without realizing it. So I think we're going to see a lot of investigation and a lot of interpretation over the next months to years that try and get to the bottom of why there's that difference, and whether it comes down to purely genetic. I would be surprised if that were the case. I am sure that there are access to healthcare issues. I am sure that this also has to do with the comorbidities that we know, things like obesity and diabetes, which we know are higher in non-white populations. And I think that we'll find things that have to do with how closely you live next to other people, whether it's within your household or whether it's the population density in the neighborhoods in which you live, that are going to be relevant too. So I'm guessing it's going to be multifactorial, but that reflects my own background in genetics, public health, and social psychology. So I'm bringing all of my background into play here and guessing that all of them are going to play a role.
Great, thank you. Council, questions? No.
Thank you so much.
I do.
Oh, yes.
Sorry. For an employer, will you suggest if their employee was exposed to just isolate for the 2 weeks and then get the test, or take the test right away and then another after the 2 weeks?
I think because of the practical aspect of the lag, that what we're finding out is that you were exposed to somebody a week ago who just got their positive test today, and that to try and identify the people in your life over the last week with whom you've had true exposure, not just in the same room, but you've spent time, in close quarters, more than 15 minutes, less than 6 feet. I think because we're trying to identify all of those people going backwards, that it makes sense to have a test when you find out that you've been exposed, and that the question is, more, do you need then a second and a third test through that 14 days, or is it practical to just quarantine if you had a true exposure, but for the sake of all the people around you, find out if at that moment in time you test positive. And the reason I say that is because I think that we will find, and the early data support, that if you have a negative swab, you probably aren't contagious at that moment. Doesn't mean you won't be tomorrow or the next day, but at least if you told me that last week I worked elbow to elbow with somebody in a restaurant who now got his positive COVID test today, and you swabbed me and I were negative today, I would bet that all the people I had close contact with over the last week don't have to worry about me, because if I'm negative today, I probably wasn't transmissible. But the frustration is that we then don't know for a whole week whether all those people I came into contact with last week have to worry. And so it will greatly accelerate the process when we have a point of care test, but it will still make sense to get tested sooner than later so that you know what to tell all the people in the last week that you've come into contact, or at least since you last were exposed to that individual. So for me, getting tested now or as soon as you find out makes sense so that you can notify the people over the, from the last time you saw the person who tested positive until today. You can notify all those people that you came into contact with that you might have exposed them as well.
Did that answer your question?
I guess I'm just wondering if, they're negative and then they quarantine for the 2 weeks, and then on the 15th day, they do develop enough to have the virus, but don't get tested. And
yeah, no, you're asking the question that every time I put the lecture together, it bugs me. So what if you became an asymptomatic carrier on day 13, but you got tested on day 7?
Right.
So could you have exposed people in between as an asymptomatic carrier? That's sort of, the way it works. Because once you find out you are a true exposure, technically you should quarantine, and that includes from your own family. And that's why I say it's important to understand that exposure is not just being in the same room, but it's being close with somebody for an extended period of time. And if you were wearing a mask, or if they were wearing, or both, then it may be impossible. But we don't want to take the idea of an exposure lightly. But if you were truly exposed, you should be quarantined for 14 days following that exposure. Or if you test positive or develop symptoms, from 10 days from that point forward. So I think, a true exposure means you should be quarantined, and it doesn't really matter what the tests say, because you could turn positive all the way out to that 14th day. So that's why I say, for me, getting a test before then, because it's not going to change what you can do, it makes sense to me, because that way you can tell all the people from your recent past whether they should be worried. So it is part of that case contact testing to be able to go back, even if it's just a couple of days, and tell people, hey, I didn't realize I was exposed to somebody, but you should, now, depending on the nature of the exposure, you may need to then go into quarantine. And then, if they get their test result back and they were negative today, then that means they probably were not contagious for the preceding days. Does that make sense?
Yeah.
It'd be easier to draw with a pen, but it's really looking backwards, not forwards. That is the rationale for why I think you should get tested, so you know who to inform that they were exposed.
Okay, thank you.
And just one other question. Would your advice be to people that are exposed that, or that have contracted it, to be very upfront and open about that instead of being maybe ashamed or something like that?
Yeah, no, absolutely. I mean, it's you know, I mean, there are a few people where I'll admit, I'll look down my nose if you went to a COVID party and had a pool going to see who could catch it fastest. I would probably look down on you if that were the case. But for the most part, you know, these are people who are trying to live their lives, and they are trying to avoid catching it, even if they know that they're not likely to have a lot of complications. But they have people in their lives who they don't want to get sick, and so it's not their fault. It's the fact that this virus can be transmitted when people don't have symptoms. And, you know, you could live your life in a bubble and you could, you know, isolate, and a lot of people have. And they, you know, I think resent the fact that there are other people out there living their lives and doing things that maybe are a little bit more reckless. And so I hope that when we get into these discussions in our household, you know, we quickly extend it out into, you know, if you're going to look down on people for going to a barbecue on the 4th of July and potentially contracting it, then you should be looking down on the people who eat at McDonald's, and not to pick on just on McDonald's, but even In-N-Out, which is sacred to me, and that are drinking sugared drinks and are smoking and are not exercising at least 3 days a week. There are so many other things that affect public health that you can look down on people on, that why draw the line with coronavirus? And so I would hope that we don't get into this sort of shaming and blaming kind of culture the way that we have. It's unfortunate because, you know, again, much of the disease that we see is based on, you know, personal choices, and particularly with the elderly, what is just now starting to percolate out is how much depression and how much suicide and how much drug use there has been, not just amongst the elderly, but amongst everyone, over the anxiety surrounding coronavirus. And that's where we, in the medical community and in the press and in politics and in public health, have failed society miserably, because we have whipped up so much fear to try to get people to comply with the guidelines, that we've created other diseases that in Southern California, at least until, you know, and I think it probably still holds true, but the last time I checked was in May, we had more deaths from people who refused to go to the hospital because they were afraid of catching coronavirus and decided to sit at home having their heart attack or stroke, or people who took an overdose, or, you know, old people whose last, you know, weeks and months on this earth were spent in this bubble where nobody would come in and talk to them. You know, I don't think that we've handled this the right way, and in many cases it's because we've tried to be overly cautious in the name of trying to limit spread, not realizing that we were going to have damage in other areas, whether it's mental or true healthcare damages. And our coroners have full body trays, not to get too graphic, of people who shouldn't have died because they were terrified because they watched CNN and they watched Dr. Gupta washes Cheerios with bleach, and they're afraid to leave the house when, you know, we've blown it way out of proportion, and we've justified it by saying we got to get people to wear their masks by scaring them, and we've literally scared them to death. And so not everything is as easy to interpret as it seems on the surface. And so for people who are out there doing stuff, who are opening their businesses, who are visiting their grandma and grandpa, you know, it may be that they've got it more right than we realize, and hopefully we don't pass judgment until we have all the answers. And even then, have some empathy for each other, because everyone's doing the best they can, and it doesn't do any good to shame people into making other bad decisions or just feeling overall miserable. All right, I'm off my soapbox.
Thank you. That was very, very good.